Thank you for joining us for this Advent Health virtual seminar.
Hip arthritis is basically defined when that smooth, glistening cartilage that caps the joints erodes away. When that erodes away, you start to see a bone exposed, and you can get bone-on-bone deformity. And then oftentimes it's very disabling, and it requires some form of treatment. You can see that in these images here. On the very left, you can see the intact cartilage, and then towards the center, you see where the cartilage has eroded away, and then on the right, you can see in the x-ray, there's bone-on-bone change. This is a very disabling condition that we oftentimes have to treat in the office with injections, anti-inflammatories. I'm going to go over that in the upcoming slides, but also subsequently hip replacements. So what causes hip arthritis? Most commonly, we see patients who have osteoarthritis, and that's that typical wear and tear pattern, kind of like losing tread on your tire. Other forms of arthritis include rheumatoid arthritis, which is really more of an inflammatory disorder or autoimmune disorder. Of course, you can have trauma, things like hip fractures, and then there are pathologies called avascular necrosis when you've lost blood supply to your femoral head. What are the signs and symptoms of hip arthritis? Oftentimes, and most commonly, patients will come in with groin pain. Sometimes it could be buttock or lateral hip pain, but most often groin. With severe cases of arthritis, it can radiate to the knee. Oftentimes, the pain is made worse with activities such as walking, running, exercise, standing. It's oftentimes improved with rest. You can have clicking or catching at times. And sometimes you could even have night pain or difficulty sleeping due to severe arthritis. Now we'll touch on knee arthritis. Here you can see on the left that smooth, glistening cartilage has been eroded away, and you can see exposed bone. And there's a cartoon in the center showing exposed bone on the inside and outside of the joint. And on the right, you can see x-rays demonstrating bone-on-bone articular disease on the very right radiograph. What are signs and symptoms of knee arthritis? Very similar to hip arthritis, pain with activity. Sometimes pain can radiate down the leg or up the hip a little bit. Pain is aggravated with activity and oftentimes improved with rest. You can have locking, catching. You can have instability or giving out of the knee. And again, night pain typically occurs when you have severe disease. What causes it? Same thing. The same causes that are associated with hip arthritis are associated with knee arthritis. So osteoarthritis is the most common cause, and that's that wear and tear arthritis. Again, rheumatoid arthritis, trauma, and you can also get arthritis after suffering a ligamentous injury like an ACL tear, meniscal tear, remotely. What are the non-surgical options? And I think it's important to mention that as an orthopedic surgeon, frequently I'm managing patients conservatively. So although I do lots of operations and do lots of joint replacements, a big bulk of my time is spent in the office educating patients and trying to at least improve their pain with conservative measures. Really important is diet and exercise. We'll talk a little bit about weight loss in the upcoming slide. Sometimes in severe cases, you might need to use a cane or a walker or some type of walking assist device. Bracing can sometimes help. We'll talk about medications, different types of injections, and then supplements. Ultimately, it's my job to keep you active. And again, that means I'm not just doing operations. I'm really educating you and hopefully treating your pain effectively with conservative measures. Balanced diet is key. I think people underestimate this. I think that the food pyramid is probably not the most accurate way to assess or manage a person's diet. But it's important to understand lots of lean meats, fruits and vegetables, nuts, and really minimize intake of carbohydrates and sugars. Ultimately, that leads to weight gain and is really problematic, especially if you're a diabetic or have other comorbidities. Basic things like multivitamins, good nutrition. I do recommend to most of my patients to take 2,000 international units of vitamin D as well as calcium. And if you have any risk factors associated with heart disease or peripheral vascular disease, baby aspirin is not unwise. Weight loss is extremely important. Unfortunately, with the epidemic of obesity in the United States, we're seeing really an epidemic in arthritis in the hip and knee. For every 1 pound you lose off your body, it's about 3 to 5 pounds of weight off your hip or knee. So if you're 50 pounds overweight, it's 250 pounds off that joint if you're able to lose that weight. It's significant, and the same goes if you're gaining weight. So if you gain 10 pounds, that's 50 pounds on that painful hip or knee. Range of motion and stretching, really important, especially with the hip, I would say. A lot of times this alone can really help minimize pain. I usually recommend to my patients spending 10 minutes in the morning, 10 minutes in the evening working on flexibility training. Strengthening, just as important. I'm a big believer in weightlifting. I usually emphasize in the office the importance of quadriceps strengthening, hamstring strengthening, and core strengthening. Your muscles around the joint behave like an internal brace. And if you can strengthen those muscles, a lot of times you'll offload the joint and decrease the pain. It really goes hand in hand with conservative management to have a strengthening program. Aerobic exercise, again, very effective means to keep weight down and also just to keep your head clear and get out and enjoy the weather, especially in today's day and age with COVID. But certainly this is really good to do. I think cycling is a terrific exercise. It's not high impact, and it also helps to strengthen the quadriceps and is really effective at strengthening the muscles around the hip and knee. So on to medications. There's a multitude of medications we typically use for arthritis management. Traditional medications, things like aspirin, ibuprofen, naproxen, or classic anti-inflammatories or non-steroidal anti-inflammatories. We do have prescription type medications. The most common ones that I use are COX-2 selective inhibitors, medications such as Celebrex and meloxicam or Mobic. They're pretty effective and typically only have to be dosed once daily. Topical pain relievers and creams and those sorts of things, they can be effective at times, probably more effective with the knee since it's more superficial. Certainly it's low risk and doesn't really impact one's health, especially if you have other comorbidities, but probably not also the most effective means for pain management. A lot of my patients ask me about glucosamine chondroitin. This is a natural occurring supplement that oftentimes patients will use for arthritis management. I think there's some important points here. There is some literature to suggest that this supplement can help reduce pain. There's also literature to suggest that it's not effective. So it's really somewhat contradictory. Usually what I tell my patients is that if you're trying it, you've tried it for maybe 3 or 4 months, and you find that it's effective, it's certainly a low cost and safe means to help your pain. If after 3 or 4 months it's not that effective, I would probably abandon it. So injections. Injections are a really helpful way to manage both hip and knee arthritis. I do lots of injections in the office. The most common one that I do is cortisone or corticosteroid. Typically we mix that with a little bit of anesthetic and inject it into the hip or knee. When I do it for the hip, I oftentimes use ultrasound or X-ray or fluoroscopy to guide the needle, but it's really an effective way to help manage one's pain. And then ultimately, when all else fails and we've tried all the conservative measures and it's just not working and the patient is unhappy and not experiencing a good quality of life, that's when we start to discuss things like total hip and total knee replacement. So really, total hip replacement we'll talk about first. It's an exceptional means to reduce pain and get people back to their normal level of function. Ultimately, what I like to say about this is that patients oftentimes can forget about their hip, which is, when you were 20 years old, you didn't think about your hips or knees, and that's really the goal for a hip replacement. We're trying to get the patient to forget about their joint. So to talk a little bit more about hip replacements, there are some smoke and mirrors, and I try to tell the patients when we're in the office that there are some really important things that one should look for having a hip replacement. Ultimately, the implants have to be really tried and true and designed well. In today's environment, there are a multitude of smaller companies that sometimes, in my view, are probably not designing the best products. So having a good, solid implant is really important, and the surgeon's understanding of that implant is just as important. Ultimately, the surgeon has to be meticulous, and the components have to be implanted well for that patient to have a good outcome. And then, of course, after the operation, it's a combination of education and good physical therapy to make sure that patient rehabs completely. I do a direct anterior total hip arthroplasty approach. What is that? So a lot of times patients will come to me asking me about different approaches. A direct anterior approach means that we're doing it from the front. There's a natural muscle plane that we can dissect, and simply move the muscles to the side rather than cut or detach them. Ultimately, where this is beneficial is that the patient's early recovery is much easier and probably a little faster. And then also some other benefits are that we get to implant the components in a more accurate position because we're using X-ray or fluoroscopy to guide component position. My typical timeline for total hip arthroplasty is usually about 2 to 3 months for scheduling. The surgery itself takes about 50 minutes. The hospital stay, we're now doing these surgeries either outpatient or the patient will stay overnight depending on their comorbidities. We'll typically use home rehab for the first 2 or 3 weeks, and then usually 2 to 3 weeks of outpatient rehab. Another benefit of direct anterior total hip arthroplasty is the fact that postoperative hip precautions are not necessary after the operation. Typically, after a total hip arthroplasty, I'll tell my patient they can't drive golf balls for 3 months, don't cross their legs, no yoga, no lunges. So those are typically activities a lot of patients are not doing for those first 3 months anyway. When a patient has a posterior hip approach or an approach from the side, you can't bend over past a certain degrees of flexion. You can't cross your legs. When you stand up from a seated position, you have to spread your legs. And if you don't, unfortunately, sometimes you can dislocate. So that's a real benefit of direct anterior total hip arthroplasty. In terms of how long do the total hip replacements last, there are a lot of variables. I will tell you one of the most important ones is meticulous surgical technique and accuracy in component position. If the components are malpositioned, the chance that they're going to fail early is much higher. So it's really important for the surgeon to understand that and the surgeon to relay that to the patient. Now on to knee replacements. First, we'll talk about partial knee arthroplasty. This is a love of mine. I trained with one of the fathers of partial knee replacements in Boston. So I like to do these operations. They're fun. They are a little bit challenging at times, but I think patients really benefit from them. It's really important to understand that some patients are just not good candidates for partial knee replacements. There's a very specific list of criteria that the patient has to meet. Specifically, the patient has to have single arthritic involvement in just one of the compartments of the joint. The ACL and PCL, the main ligaments of the knee, have to be intact, and the patient has to be a healthy weight. If the patient is over usually 210, 220 pounds, this might not be the best option for them. Benefits of partial knee replacement are really profound. Again, the recovery is probably a little faster, a little easier. There's not as much pain when compared to a total knee replacement. The complication rate is typically lower. Things like infection, recurrent pain, mechanical issues are typically less common with partial knee replacements. And ultimately, the knee will usually feel more natural compared to a total knee replacement. Usually with a partial knee replacement, a patient is more apt to forget about the knee, where a total knee, usually it feels a little different and the patient knows it's there. Total knee replacements are still great operations when you need them. They're very effective at reducing pain from arthritis. Patients really can get back to their normal, typical everyday function. And ultimately, the survivorship of these implants is really excellent. There are benefits of partial knee arthroplasty compared to total and vice versa. Ultimately, that's a discussion that should be had in the office with your surgeon. So my timeline for partial and total knee replacements is the following. Typically, it takes about 2 to 3 months for scheduling. Usually it takes about 40 to 45 minutes for a partial knee and about 50 minutes to 60 minutes for a total. Hospital stay, usually partial knees go home. Frankly, total knees usually go home as well. At most, patients will stay a day or so. Typically, patients will do home rehab for the first 2 to 3 weeks, and then 2 to 3 weeks of outpatient therapy. Usually patients are getting rid of the cane with a partial knee at 1 to 2 weeks, and with a total knee getting rid of that cane at about 4 to 5 weeks. So in summary, hip and knee arthritis is a disabling condition with environmental and genetic causes. It's treated through diet, exercise, and medically and ultimately surgically with joint replacements. The surgeon's main job is to keep you out of the OR and hopefully treat you effectively with conservative management until the time where you really need a joint replacement. Direct anterior total hip arthroplasty is a great surgery. It's a muscle-sparing technique that improves early rehab and ultimately improves component position. There are no hip precautions typically after the surgery, or I would say reduced hip precautions, and really idealize component position and ultimately implant life. Partial and total knee arthroplasty are both great techniques in reducing pain and restoring function in patients with arthritis. Partial knee replacement ultimately provides better function and a more natural feel than a total knee replacement, but ultimately total knee replacement is really an effective and reliable treatment for patients with more advanced arthritic change and patients who are not meeting the criteria for a partial knee replacement. Thank you again for joining with me today. I appreciate your time, and hopefully I've helped answer some questions that you might have.